So the question, my screen visible?
Yes, sir.
So acute kidney injury in intensive care. If this is the word, then you have to modify your answer slightly. As what are the conditions of patients in intensive care which can result in acute kidney injury? And this is frequently observed in critically ill patients who have gone through episodes of hypotension because of sepsis or because of hypovolemia or because of trauma or because of uh, nephrotoxic drug usage. So all these things will be the main reasons for the occurrence of acute kidney injury. And when you say acute kidney injury, it happens in a very short period, just like VAP occurring within 48 hours of mechanical ventilation. AKA also develops it in a short period. The kidney starts declining in its function in a very short notice, unlike your CKD, which gradually the GFR from normal 90 to 120 goes down to 60 for some months and then goes down to 40 some months. Then ultimately it goes to the end stage disease of 15 ml or less per minute. So that it doesn't happen like that. It happens within a very short period of time, and that is the reason why it is called acute kidney injury. And it is a sudden and rapid decrease in kidney function, occurs within hours to days, and initially it may be reversible. If it is merely due to hypovolemia or hypotension and occurs say for about 12 to 24 hours, this may be completely reversible and the kidney may come back to normal activity. Whereas the patient who develops CKD, chronic kidney disease, it is a progressive disease. It doesn't come back to normalcy. So that is the major difference between AKA and CKD. And it is characterized by azotemia, that is accumulation of urea, it's called azotemia, and reduction in urine output. And it may range from a very mild form where the urine output may be absent for 12 to 24 hours, then completely resume and become normal, or it may get prolonged for 3 to 4 days, where it may require more intensive therapy. So the spectrum is very, very different from mild to severe and leading to sometimes complete kidney failure also. And the criteria to identify the AKA, there are several criteria. These are called the criteria to identify. One is called the rifle criteria. The other one is AKIN criteria, acute kidney injury network, or KDIGO, kidney disease improving global outcome criteria. These are the three common ones which are used. So in rifle criteria, the first three letters RIF, they stand for the categories of impairment where there is a risk for kidney injury or there are already a damage has occurred in the form of an injury and the kidney has started failing. So these are three grades of the impairment that is occurring and two categories of long-term renal outcome. One is the loss, the other is it may become an end-stage renal disease. So in the rifle criteria, the first three letters of the acronym stand for the actual damage that has happened, and the last two are the outcomes of those damages. And the risk, when you say there is a risk, that means that two things are taken into consideration. One is the creatinine, another is the GFR. So if the creatinine increases by 1.5 times the baseline, or the GFR, which is in the clinical settings, it is by the output, urine output. So we cannot be measuring the GFR all the time or calculating using the Cobb-Graft formula. So we use the urine output as a clinical marker for the risk that is involved. So increase in the creatinine by more than 1.5 times the baseline value, or decrease in urine output less than 0.5 ml per kg per hour. So it can be independently this or both is called the risk. The second is called the injury, where there is a 2 times increase in the creatinine and the GFR comes down, and the reduction in urine output, the duration gets prolonged. In the risk stage, it is only for 6 hours. In the injury stage, it is more than 12 hours. There is a decrease in urine output. And in the failure stage, the creatinine increases thrice or 3 times, and urine output less than 12 goes beyond 12 hours also. And when there is a loss, the loss of kidney function happens for over 4 weeks. That is, it may take 4 weeks to completely recover. Then it is called loss of kidney function. And ESRD, when the function is lost for more than 3 months, that is, the creatinine is always high and the urine output is low, and patient requires sometimes renal replacement therapy. And after 3 months, it may become normal also. So this is the outcome that you will see in this rifle criteria. And this AKN Hakim criteria is nothing but a modification of the rifle criteria. So there you have only 3 stages, and the stages are stage 1, stage 2, and stage 3, and there will be increasing severity as the stage increases. And again, here also the creatinine and urine output are the true parameters which are taken into account. And patients who receive renal replacement therapy are considered to have come to stage 3 criteria. Irrespective of the stage, they are in the time of renal replacement therapy. So the reason for this criteria being used are to assess the severity of the renal injury and the probable time it will take to recover, and the treatment that has to be given for salvaging that kidney function. So these are the 3 things that we have to keep in mind and use these criteria according to that. So KDIGO AKA is the presence of any of the following. Again, increasing in serum creatinine by 0.3 milligram within 48 hours, or increasing in serum creatinine 1.5 times from the baseline or the prior 7 days, and the urine volume less than 0.5 at least for 6 hours. So all the 3 criteria, please remember, are taking only these 2 things into consideration. One is the serum creatinine value, the other is the urine output, which should be less than 0.5 ml per hour, but the number of hours changes according to the severity. Now, after assessing according to the criteria, which stage or how much severity, what are the causes, possible causes? The main cause basically is renal blood flow reduction is the common pathological pathway. So unless the glomeruli receive adequate blood supply, GFR, that is filtration cannot happen. This is a very simple, basic, logical thinking. And the pathophysiology of ADK divided into 3 categories: pre-renal, intrinsic renal, or post-renal. And each of these categories have many different associated causes. We have for pre-renal, it is mainly because of lack of fluids or lack of blood pressure. Intrarenal, there may be a damage at the glomerular level or the tubular level or the collecting duct level. Post-renal, it is usually called as obstructive uropathy, where there is a obstruction to the drainage, which is causing back pressure effect and preventing the normal functioning. So this is one method of assessing the etiology. And coming to the pre-renal acute kidney injury mechanisms, hypovolemia, which is usually due to either hemorrhage or burns or GI fluid loss, like nausea, vomiting, diarrhea, etc. These are the things which cause the acute renal injury. Then hypertension from decreased cardiac output, cardiogenic shock, or massive pulmonary embolism, or acute coronary syndrome, So all these things, lack of pressure to supply the blood to the kidney, that could be the second reason. And hypertension from systemic vasodilatation, like in septic shock, anaphylaxis, or anesthesia administration. And renal vasoconstriction caused by NSAIDs contrast, which are used for treating various conditions, or amphotericin B, the antifungal, calcineurin inhibitors, or hepatorenal syndrome, as in cirrhosis liver. All these things can cause AKA. Then glomerular efferent arteriolar vasodilatation, which is causing the intraglomerular hypertension during usage of AC inhibitors, angiotensin receptor blockers, etc. Then renal causes of AKA include ATN, ischemia from prolonged renal injury, such as use of aminoglycosides or vancomycin, amphotericin, etc. And conditions like rhabdomyolysis or intravascular hemolysis. So there the tubules are affected, and that may be the cause of AKN. Or acute interstitial nephritis with drugs like antibiotics, beta-lactam antibiotics, penicillins, NSAIDs, proton pump inhibitors, infection, autoimmune conditions like SLE, etc. All these things cause acute interstitial nephritis. And glomerular nephritis, like in immune complex mediated SLE or post-infective glomerular nephritis or IgA nephropathy, which are all causes for the dysfunction of the glomeruli. And intratubular obstruction due to monoclonal gammopathy like multiple myeloma syndrome, tumor lysis syndrome, etc. So these are all the various anatomical sites of the nephron which are affected in renal causes of AKA: tubule, interstitium, glomeruli, or intratubular obstruction. And post-renal, all of us know that it could be due to calculi, renal cyst or pelvis or bladder and urethra, or it may be tumor, blood clots or neurogenic bladder, or urethral obstruction with the prostate enlargement or retroperitoneal fibrosis, pregnancy, etc. And so after the location of etiology, you must know something about the pathophysiology. What is an acute tubular necrosis? It is a cellular insult secondary to ischemia or direct toxin, resulting in the effacement of brush border, cell death, and decreased function of the tubular cells. So tubular cells lose their capacity to reabsorb, do their normal function, and usually it is identified by the presence of the gas or the granules that are secreted from the urine. So intrarenal causes of tubular obstruction could be myoglobin, crystals of urine, uric acid in tumor lysis, and immunoglobulin monoclonal gammopathy. And other intrarenal mechanisms are glomerular nephritis and acute interstitial nephritis, which is due to immune-mediated conditions where vasculature inflammatory response leading to glomerular and tubular damage which happens. And in post-renal, it is usually a reflex phenomena because of the obstruction. Urine goes back, causing decreased renal perfusion, tubular atrophy, and interstitial inflammation. All these things are happening because of the retrograde pressure effect. So this is the pathophysiology. And what is the history and physical examination to find out the presence of AKA? Focus on determining the etiology and progress can assess. History points towards hypovolemia or hypotension. Then treatment is guided towards the replacement of fluid and correction of the hypotension with vasopressors. And look for inciting events like diarrhea, vomiting to treat that initial insult that is causing this hypovolemia. And if a patient already has some history of CKD, compromised renal function, then that can result in what is called acute on chronic condition. So a chronic kidney disease patient may develop a acute shutdown or acute kidney injury. So this is more important when a patient who is not diagnosed with CKD, whose GFR is between say 30 to 60 ml, is in the stage 3, where he comes for an incidental surgery and requires anesthesia, then this condition becomes more important, because any hypovolemia or hypotension can convert this CKD into an AKI. Acute kidney injury can happen in that. And it is very difficult to salvage, because this patient's GFR is already low. It will not improve by correcting the hypovolemia. So we have to prevent the occurrence of AKI in this patient by titrated fluids and maintaining the blood pressure without hypotension intraoperatively. So that is the most challenging thing in a patient who is not on RRT, that is renal replacement therapy, but diagnosed with CKD with a moderate stage 2, 3, in stage 3 or 4 condition. There you have to be worried about this. Then review the past medical history and comorbidities, which will, especially if a patient is a known diabetic or hypertensive, and if he comes to the ICU just for some reason, then it may cause more chances of AKI. You have to be very careful with that. Now, physical examination, if you see the skin, there may be digital ischemia, butterfly rash, and the purpura suggestive of vasculitis. Maculopapular rash may indicate the drug-induced acute interstitial nephritis. Needle mark may suggest IV drug use, which can cause endocarditis. Lividio reticularis and skin infarct seen in cholesterol emboli diseases. Decreased tints are seen in hypovolemia. So dry skin with loss of skin sugar, naturally hypovolemia. Now, when you examine the eyes and ears of the patient, jaundice present may cause the liver disease, which is may be the cause for hepatorenal syndrome. There may be band keratopathy, multiple myeloma, diabetes mellitus can show macroscopic retinopathy, blood vessel narrowing associated with hypertension, keratitis, etc. So all these features also give a clue to the possibility of AKI occurring. In the cardiovascular system, pulse rate, blood pressure, GIVP rise, all these include the volume status. Irregular rhythm may indicate electrolyte imbalance related to arrhythmias, and pericardial friction rub may be heard in uremic pericarditis, and the heart murmur is often heard in endocarditis. Embolic diseases can present as cyanotic extremities. Now, how do you evaluate a patient with AKA? Just for all possible etiological etiologies of AKA, note the time of onset of AKA. So just like your the previous discussion on VAP, we must see how soon the kidney function is deteriorating, like drop in urine output or increase in creatinine. When it is happening, a sudden rise in creatinine is noted, and the inciting factor occurred in the 24 to 48 hours preceding this onset has to be checked. So you must see whether within the previous 48 hours was there any negative balance, fluid has not been given properly, or any episodes of prolonged hypotension which was not corrected within reasonable time. So that all can be checked to find out the evaluation of AKA, and whether any contrast has been used to find out or make a diagnosis, that also has to be noted, and whether any AC inhibitors or ARBs which could be. So AC and ARBs, though they are considered the first line of treatment nowadays for treating hypertension, they can be a double-edged weapon. So in patients who are prone for AKI, these drugs can contribute to the formation of AKI, and urine should be checked for electrolytes, protein, osmolality, and albumin to creatinine ratio to find out whether it is AKI. And CT scans can give evidence for nephrolithiasis and urolithiasis. Urine microscopy may show brown cast in ATN, that is hemorrhagic cast, or white blood cells in acute interstitial nephritis. So this microscopic examination is also very valid and useful. And sterile pyuria is the specimen acute interstitial nephritis. It's the most common thing that happens. There will not be any growth in the culture, but you will see plenty of pustules in the urine routine examination, which indicates there could be AIN. And creatinine is commonly used to evaluate for AKI, and neutrophil gelatinase associated lipocalin, NGAL, which is measured both in the plasma and urine, is a biomarker which may be more sensitive and elevated earlier in the course of AKI compared to creatinine. So nowadays we are trying to, because creatinine usually raises only after 75% of the nephron activity what gets destroyed. So it is a very late marker. So we want to find out the damage much earlier. Just like as I told you, the AA is going to give you a future in VAP management by not waiting for culture report and then treating. This identification of this protein in the plasma or in the urine, which is called NGAL, neutrophil gelatinase associated lipocalin, may change the treatment of AKI without waiting too much for the creatinine rise to happen. And kidney injury binding protein, which is a retinol binding protein, cystatin C, alpha beta microglobulin, urine uromodulin, or other biomarkers, out of which the cystatin C is also very useful. So these two, NGAL and cystatin C, are being worked out as important biomarkers. Just look your troponin nowadays. I'm telling you about the acute coronary syndrome. In future, these two may be the markers with which you can easily diagnose the occurrence of AKN well in advance, and treatment can be initiated. And the use of biomarkers, the only problem now is not widely available. And studies are still being done to make sure that they are really sensitive in assessing or identifying the AKI. A kidney biopsy is an excellent tool, but it is more invasive and it can cause bleeding and other things. So that is not being routinely used. And the markers of tubular function can be calculated to help distinguish between pre-renal, intrarenal, and post-renal causes. And fractional excretion of sodium and urea and urine osmolality, as we mentioned, are all valuable tools to identify intrarenal AKI. So these tests are useful only if you suspect intrarenal problems like ATI. And the parameters affected by drugs such as diuretics, these parameters are also affected by drugs like diuretics. So that is the reason why these are all also not very popularly used in assessing the AKI. And so no single marker can be reliably used in isolation to distinguish the causes of AKI, and clinical presentation must be considered in all these things. And treatment and management, if there is no contraindication, first thing is a fluid challenge. So make sure that there are no cardiac contraindications, mainly patient with compromised cardiac function who cannot tolerate a fluid overload. It may be disastrous to give fluid challenge, which will result in pulmonary edema. So if there are no cardiac contraindications, the first choice will be giving a fluid challenge. As he rightly said, a 500 ml bolus within 30 minutes, and see whether there is a improvement in the urine output. And acute tubular necrosis and other intrarenal causes are slow to recover and take weeks or months to complete recovery. And diuretics may be required for oliguric phase of the acute tubular necrosis, but the dosage required will be very high. They will not respond to the small doses like 20 milligrams or 40 milligrams what we usually try. It may require 100 milligram or 200 milligram doses of Lasix in these conditions. And many medications may be renally adjusted once the patient develops AKI. So all antibiotics, especially the antibiotic like vancomycin, gentamicin, and other things, aminoglycosides, have to be very carefully used in these conditions. And dietary ingestion of potassium and phosphorus also should be monitored and reduced. Conditions, complications that can happen because of ETA, hyperkalemia. So that is managed by dietary restriction, insulin, dextrose, and beta agonist infusion, potassium binding resins, and calcium gluconate to stabilize the cardiac membrane. So this is a common question in both VIVA as well as in theory exam. So that's the reason why I have given this answer. And if all these conservative measures do not work out, then dialysis, one of the indications for dialysis is to salvage the patient from hyperkalemia, which can result in cardiac arrhythmias, especially ventricular tachycardia and fibrillation. The second important reason is volume overload. So as the patient's urine output drops, you have to make a very, very important balance between the intake output. So we cannot blindly infuse fluid in those patients, then they will develop edema first initially on the dependent areas, and finally it will land up as a pulmonary edema. So high doses of IV furosemide are needed to correct volume overload, and short-term renal replacement therapy may be needed if the patient does not respond to the IV doses of furosemide. And hemodialysis usually performed through temporary IJV catheter in these patients. And if the patient is hypotensive, then you cannot do the regular hemodialysis. In those patients, you have to go for what is called continuous renal replacement therapy. And metabolic acidosis is another important condition which requires correction either with citrate or bicarbonate, and the other treatments directed to the etiology of AKA, like you can give vasoactive medication and colloids for the treatment of hepatorenal syndrome, cautious diuresis in cardiorenal syndrome, immunosuppressive medication for glomerulonephritis and vasculitis, and steroids for acute interstitial nephritis are the other causative treatments. Post-renal obstruction may need to be relieved operatively in certain situations, and BHP may require a TURP or catheterization. Obstructive calculi may require stenting and lithotripsy. So these are the changes that will happen: fluid overload, electrolyte imbalance, impaired immunity, and it may ultimately go in for chronic kidney disease. These are the various presentations of AKA. Complications, the same thing what happened: hyperkalemia, acidosis, hyperphosphatemia, and other organ related complications in cardiovascular system. There may be fluid overload causing heart failure, may be the cause for AKA, or it can secondarily happen because of AKA due to fluid overload also. And then the GI tract may cause nausea, vomiting, and neurologically patients may start accumulating urea, which may lead to lethargy, somnolence, and uremic coma. And the differential diagnosis of AKN are patients who have possibility of renal calculi, which is blocking, acute chronic kidney disease, hypovolemia, GI tract bleeding, decreased cardiac output, etc. And rarely ingesting excessive protein or dietary supplements can result in elevated creatinine level, which may be unrelated to kidney disease. So what the patient has been given as a dietary supplement, that also has to be taken into account. The prognosis, most pre-renal, they recover completely because it is merely hypovolemia or hypotension, which is preventing the glomerular perfusion. So that will invariably recover well because the structurally the nephron is still good functioning. And older age, duration of illness, fluid balance, diuretic use, oliguria, hypotension are all factors which influence the recovery from AKA. Okay, so that is all about the AKA. So you can classify the whole topic into first a definition, then the criteria for identifying, then the etiology, then the changes, then the mechanism, and then the treatment, and finally the complications and prognosis. This is how the whole topic can be identified.